afraid the last chair is next to me, Hardeep. So we're going to have a stakeholder panel for the next 45 minutes. And we've got representatives here from a number of different organisations who will be talking about their current immunisation training plans and also the capacity building initiatives. So with that, please let me welcome Jhilmil Bahl from WHO, also representing UNICEF. Next to me, Dr. Hardeep Sandu from CDC. And then at the end of our panel here, we have Liya from the Ministry of Health, Ethiopia. And then next to Jhilmil, we have Sarah Zizzo from USAID. And then finally, we have Dr. Chizoba Wonodi from IVAC. So we're going to welcome lots of questions from this audience. But let me perhaps get going by asking the panelists, why is immunization training important to your organization? Jhilmil, can I start with you?
Okay, so as you know, I'm coming from WHO, and WHO is a health technical agency, and especially at the headquarters level, we are involved with a lot of forming of norms and standards. And norms and standards are useless until they are implemented in the field. So always capacity building has been a priority for WHO, and WHO kind of has a convening power to bring together stakeholders, and a lot of time we organize training courses, workshops, and capacity building is a core pillar of all the activities that we do.
Great. So Jhilmil, if you're very much on the headquarters side, Chizoba, you're more on the academic side, why does it matter to you?
I mean, capacity building is one of the core, should I say, approaches to ensure coverage and equity. At IVAC, our mission is to accelerate access to vaccines, and we can't do that unless children are getting access to vaccines through the trained health workers. IVAC is situated in a, should I say, a unique position where through the academic enterprise that Hopkins undertakes, we have access to a great variety of expertise, not just in immunization, but also in evaluation and also in the learning science. So we think that we are able to bridge, bring in the expertise from the different fields, and then help translate that into, at the field. So at IVAC, because of the work we do in Nigeria with the National Primary Healthcare Agency, we're able to help the agency test out new innovations in how we can better deliver training to health workers. So it's really important for us because at the end of the day, if the health worker who is interfacing with the child does not have the skills to deliver these services, then all our efforts will be defeated.
And Liya, from the country perspective.
Thank you very much. Capacity building activities for the ministry is first priority because of dynamism in the health sector. In our health transformation plan, we have put one priority which is capacity building, not only for immunization but also for other programs. But in aspects of immunization, immunization is a priority agenda because of its cost effectiveness in promoting health, in preventing preventable diseases. So capacity building in the aspects of immunization is the first priority for the ministry, and it is being emphasized through times due to staff turnovers, and due to a change in the science of vaccine. So it is our priority.
Okay. And Sarah, from the donor perspective.
Absolutely. As a USAID, as many of you know, is a large multi-sectoral development agency, and we are, in this current climate, being challenged to really increase efficiencies and to do more, show more results with steady funding for maternal and child health programs, thankfully, but really our funding for immunization is stretched across other MCH programs such as maternal health, child health, family planning, etc. And for the reasons so eloquently put by my colleagues up here, we really do see that good training in healthcare worker capacity is a way to maximize these efficiencies and show results. We are also challenged by the measurement issue and how to really prove these results, but it's going to be very integral to achieving the goals that we set forth together with immunizations, but for other MCH programming writ large.
Thank you. And Hardeep, by no means last, what's CDC's perspective on this?
As you heard from the other colleagues here on the panel, we firmly believe that anything we want to improve, particularly health worker performance, they need to be imparted with new skills, with new techniques, and that comes through training. So effective training, which we can measure that there have been impact because of that training, is a key for CDC's approach to it, that we try to measure, evaluate any workforce intervention and also document if possible so that others can learn from what has been achieved in one country. And CDC as Global Immunization Division, which I represent, we support the priority countries from immunization point of view in terms of their program improvement and efficiencies in the program. And training comes first of all. And then you have to look at other things, but first let the new knowledge or the new technology or innovations to be known to the program.
So, very good. So all of this sounds very positive, but can I ask, how well do you think we're really doing on immunization training? And perhaps, Chizoba, with your independent perspective first, how do you evaluate progress?
I think we are not doing very well, I have to say, I'm sorry to say. We have several years of doing the same thing and not getting results, and also complacency in not getting results and in questioning why we're not getting results. Nigeria, for example, where I work, we have this, the project that we're working is trying to change the paradigm of where you have this cascade training from the, like Vio showed, from the national level to the state level to the LGA level down to the health worker. And it's funny that the reason we start out with capacity building is to train the health worker. But by the time you get to train the health worker, you would have engaged 3 extra layers. It puts you in the situation of Chinese whispers. I don't know if you know of Chinese whispers, where you start out with a statement, you whisper it to him and whisper to me. By the time it gets to her, it's a completely different statement altogether. And that's what we've been doing for several years with the TOT training. And I don't think we have that momentum yet, or the critical mass yet, to change that paradigm. That's number one. And then the second thing is that there is a lot of capture of the training enterprise, so to speak, by the the powers that be, or the powers that be within the program. And some of the people who are relevant to training, particularly academic institutions, are actually not involved in in-service training to a large extent. And that's one of the things our project is trying to do, the Step-In project is trying to do, is to bring back the schools into training. Because yes, the people in the field have the experience, they have the expertise, but many of them are not trainers. And our default is to use program managers to do this training, this cascade training. So the Step-In project, one of the things we want to do is to try and bring in those who trained us. As a health worker, you had somebody who trained you in school, so bring them back into in-service training. And then the third thing we're trying to do is to place emphasis on evaluation, place emphasis on accountability for learning. So like Vio said, it's not enough to check the box to say we've trained 50 health workers. What have they learned? And has that thing they've learned, has it translated into better service delivery. I think that's where we're falling down to a large extent. We're too complacent. We're doing things the old way and checking the box to say that we've trained 1,000 health workers. So I think we need to change in those respects.
Thank you. I know no one on the panel feels complacent, but Liya, particularly working in a Ministry of Health, do you share the same assessment of the problems we're facing?
Yeah, I do share the issues that you raised, but I would like to emphasize on the things that we are doing well too, especially in the intra-training activities. We are good in delivering the trainings, in arranging them, but we are not good in the pre-training activities that we should do, in identifying the real challenges, who should be trained and who should be retained, so that we can improve in the aspects that we are talking about, like quality, equity, and then coverage. In the post-training activities, there are big limitations, like we are not tracking the trained professionals. In my country, we train starting from health extension workers up to the mid-level and then senior professionals level, but we don't have a system that helps us to track the effect of our trainings, and a monitoring system that shows us how cost-effective that training was. So we are doing fairly well in delivering the trainings, but we are not doing well in pre-training as well as in post-training activities. I also believe that the harmonization in the training, intra-training activities between the organizations, like between the sectors. For example, in my country, when you go down from the federal to the regional levels, there should be some harmonized system that helps us to track the trained professionals. So even developmental partners who are giving multiple trainings, the harmonization between them, it should be in place so that we can say that we are doing very well.
Thank you. So if we then think about what we can do at the global level to help, either Jhilmil, Sarah, or Hardeep, what are your priorities to try and address some of these challenges?
I may start. So I think what I see in the training world that, as already rightly mentioned and Vio in her introductory remarks, that if there is an immunization system needs to be strengthening, and then we talk about training and then just do a training. And what we did last 10 years, every few years, just do a cascade training. That's not working, and why are we doing it again and again? So that's one thing I wanted to highlight, as mentioned already. But I think what needs to happen differently is that there has to be a needs assessment. You need to know what is really broken, which you're trying to fix through training. And is training the right answer for that? So that piece needs to be sort of highlighted, and that phase has to be given enough importance and timing. The other thing is that during the implementation of a workforce intervention or a training, we again, as mentioned already, that just PowerPoint. This is one way, one-sided. You just deliver a lecture to adults who do not, we know that do not learn that way. There has to be interaction around. So what is the correct delivery method for a particular training where we know this needs to be imparted to a particular group? Is the methodology correct? Is the instructional design better? So that also needs to be addressed. In the third phase, which is, I always say it within the team, within the group, is the tail end of the performance, or it's the last phase of the performance. The training doesn't end at the intervention time where the lecture was given or a workshop was organized or a group discussion was organized. The actual learning happens afterward. The health worker performance will improve afterwards once they do the activities differently or they use the new skills they have been imparted during that intervention. So that phase has to be looked at, documented, evaluated, and then we close the loop again where we still have some gaps, come back, do the right instructional design, and then continue the process. So it's a continuous quality improvement process which needs to be looked at systematically, and that's not happening currently. We are just doing a piecemeal, reactionary, and when a country needs to strengthen immunization system, training comes to mind, just do a training, check a box, spend a few $1 million in a large country with cascade training, but that has not helped us. We know the needle has not moved in the coverage area.
So Hardeep, you talked about needs assessment, better methodology, and then continuous improvement. I mean, Jhilmil, from WHO's perspective, is that the right recipe, or does more need to be done?
No, I totally agree with Hardeep. And I mean, at WHO, we spent a lot of time getting the materials just right. So we are not doing as bad as developing materials for new vaccines or other routine immunization strategies and things, but we've begun to realize that that's not sufficient. And so now the other aspect that I want to bring in is about equity. So we talk about equity, it's a big word nowadays in immunization. And I actually also think for the health workers, it means that all health workers should get high quality training irrespective of where they are, whether they are in a village in Nigeria or India, or they're in a city close to the center in a developed country. So all of them should have the same access to high quality training. So that's something that we want to engage with, and we're also looking at using technology, because a lot of the things that nowadays technology can do for you, so the learning management systems, for example, on their back end can actually track where did the learner fumble on a particular activity, what was the pace of their learning. So a lot of data we can capture and look and enhance the training, and technology now can provide these tools. Chizoba yesterday mentioned that they have like small things like WhatsApp group of people who attended a face-to-face training, so they can continue to interact post-training. So there are many opportunities now that technology can offer, both in terms of improving the methodology, but also for monitoring the training as the trainers take it, and afterwards also for corrective action.
So I see a lot of people nodding at these various ideas, which is great. What's holding us back? What are the main impediments to us actually moving forward and implementing some of this? Sarah, do you have a perspective?
Sure. I mean, I think oftentimes as a human, we tend as subject matter experts to get very ingrained into our perspective. And this is not only for immunization. I think this is true for every field. I think that really trying to identify the problem that we're trying to solve and not jumping to the solution, because the solution tends to be a top-down approach. I think that these intractable health issues and coverage and equity are things that we've made a lot of progress in certain ways for a long time, but perhaps there's another issue that we're looking at. Perhaps it's mentorship, or how to connect the end user of the training with farther tools. As we know, people learn best by doing. So when you're out in the field and you're starting to implement the things that you learned, how can we provide better support there? So sometimes I think it's breaking down the problem into smaller pieces and stepping back and re-asking the question for the solution. And I don't think this is something that we have to start from scratch on. I think that we can really look to other sectors and other health areas and the types of things that they have been doing. We have a very vertical siloed health programming, but we have made strides in places like PEPFAR or PMI or some family planning programs to answer some of these questions. So some cross-fertilization, stepping back from our subject matter expert hat and really putting on a broader hat and thinking about a people-centered design of these things.
Interesting. Chizoba, I was reading some of your published project work. You talk quite a lot about incentives for training. How fit for purpose today are they? So a leading question.
Yeah, I think that as we all recognize, the status quo is that people are incentivized to attend training, and for the most part, the incentives that are out there are monetary incentives, per diems, and things like that. But I think there's some literature to show that money is not the only thing that can incentivize learning. that even recognition can incentivize that. And like what Jhilmil mentioned, I think that even in our small experiments in Nigeria, we're seeing that even recognition from peers and linking them to a small community of practice, following the training, can mobilize them to do more, to try to learn on their own. A practical example is we did the training of core trainers in 3 states. And we found that in one of the states, one of the southern states that had not had a lot of exposure to polio campaigns and the subsequent trainings that came with that, we found that in the southern states that the core trainers were actually less informed about immunization than the core trainers in the north. And so when they went back to their state, they on their own took the reading materials and were studying, because they all had to contribute information to that WhatsApp group, and they didn't want to be left behind. So the incentives are not just monetary, so we need to find what those incentives are and put them on offer. The other thing we've looked at is the incentive of certification. And you see, I want to just extend that a little bit. I feel like the way we do training right now incentivizes, the biggest incentive is for people to come together and do the training. However, we need to find a way to make it more efficient. It's actually expensive to do training the way we've described, to have small groups, to have that one-on-one interactive this thing. And then we come to the problem of scale. How do you scale that up? There is not enough funding within the, say, government system to sustain that kind of training. So could you look at the, should I say, the gold standard of training as an incentive for learning? And I was discussing with him yesterday, where you could bring in technology, and there is a pathway using technology, using simpler, easier learning approaches. So you could have them, learn a few things on their laptop, and based on how much, whether they've passed that or not, then they can then graduate into a, face-to-face type learning, the gold standard learning. So getting to learn in an environment like this can be an incentive for them, having learned things along the pathway to that. I don't know if that makes sense. So that's another way of looking at incentives. So we need to be creative in how we structure the training, so that the training itself could be an incentive or could be along the pathway to an incentive.
Very good. I've got lots of additional questions, but I'm also conscious that there might be a lot of questions from the audience. We do have mic runners, but we're going to try this. If you actually speak loudly enough, I'll try and repeat your question back. And then hopefully we can get to discussion going. And feel free to address your question either just to one individual panelist or the whole panel if you prefer. Who'd like to go first? Sir.
Thank you very much. I'm Femi Oyewole from Nigeria, MCSP, RI. 2 things I would like to contribute, and I think we should look at it. The way I look at it is this. I asked my engineer friends, what is the meaning of cascade? And they said, if water is cascading down, it's supposed to gain more power. And that is how you generate electricity. And I think we got it wrong. When we say cascade training, and like Chizoba rightly said, by the time you are cascading, actually it's no more a training, it has become a briefing at the most peripheral level. So I think we should go back to what is cascade. We want energy, and we want energy at the most operational level. So that's the first thing. And another thing I think we should also learn to do is, Chizoba again talked about the people who taught us. I think we should combine 2 things. The best way to do it, to me, is how do we ensure that we bring the field into the class and take the class into the field. Because taking the class into the field is we get our lecturers, teachers, and so on to see what is happening in the field. And like Vio said initially, that is the way we translate the theory from the class into the practicals in the field. And then we bring the people in the field who do this thing every day to the class to let us know this works in the field, this may not work in the field, what is the alternative? In terms of incentivizing, I think the incentive may not necessarily be monetary. I think one major thing we also should learn to do is when we do the training, how much do we go there to learn how much they learned at the field? I mean, during the training. In other words, what has been the, and I think you also mentioned it, the impact of the training. I think it's about time we start measuring. If you take me for a TOT, how much I'm able to impact the people I'm supposed to train after a few months, 6 months, 1 year. I think these are the things, to me, we should start to learn if we're actually going to change the status quo of what we call the 17th century training. Thank you.
So a rich question there with elements of can we fix cascade, bridging the divide between theory and practice, and then also measurement. Let me start just with, if I understand your question correctly, about cascade training. Is it fundamentally flawed, or are there ways in which it can be made to work effectively? Liya, do you have experience in this?
Yeah. Cascade trainings are usually the only ways that we use, because for a large country like Ethiopia and Nigeria, it is not easy to reach lower level like with a central capacity. So what we usually do is we call all regional colleagues to the center, we pull them, then we train them. But the challenge is when they go back and cascade it. So the major things that we agree usually is on the days. So when they go back and cascade it, they usually compromise the days of the training, like the duration. If the training is for 4 days at central level, then it goes to regional level and it will be 3 days, and then lower, then it might be as low as 2 days. So what we are negotiating and agreeing with them is, one, we will deliver like technical support, or our partners supports in this regard. We go in their regional trainings and support them technically, and of course monitoring them how they are doing it. And the other way is not to compromise the budget that is going to be transferred for them. Then we will allocate enough time for them so that they will not be enforced by the available budget to compromise the days. So these are the practices that we are doing so far, but now we have planned to further enrich it by asking full technical reports, not only financial reports that comes up with like statement of expenditure, but to have full technical report how the cascade training was done. So these are the things that we are doing so far.
I think Jhilmil, you wanted to come in?
Yeah, so 3 years back we had done a literature review of cascade training and trying to see if there was any good, as you mentioned in your question. And what we found, the heart of the problem is the trainer. So at the national level, you find people who are technically sound but might not be great trainers, and they are the master trainers. So they don't come with training capacity and nor the time, because they are technical people, they are managing the national program, so they don't have the time to go down as the training cascades down to follow it through and see whether the messages are getting as they were intended to. So there's a lack of time commitment from them, and also they're technical experts and not training people. So the way that we thought we could address that problem was to have sort of the role of that trainer is a little bit minimized, not in the sense that if you get a bad trainer, you still get quite a high quality training. And for that, we started to use videos. So all the health workers, irrespective of where they are, they're watching the same video. For new vaccines, we did that. And so that the role of the trainer is a little bit, you know, everything doesn't depend on the trainer. The other thing that we are suggesting is that, you know, the master trainers get this training of trainers, but they are expected to at least attend 3 trainings for the trainers that they have trained. So you know how they do it in teaching college institutions, you know, when you're in school, you're getting trained to become a school teacher, your supervisor sits at the end of the classroom and is observing. So we're saying that, you know, the master's trainer job doesn't finish by just giving the training of trainers. They have to go and observe, support, and provide feedback so that the new trainer that has just got trained and is delivering the training for the first time feels supported and gets some feedback on their training skills, not just on you know, how good they are technically. So, but it still remains an issue, but these are certain things that we are thinking of coming up with some guidance on. A cascading principle is not so bad, but you know, to enhance it, these are some things. And what Femi mentioned is really great. Go to the field. I would take it even further. Why come to the center? Why bring all the health workers away from their job and bring them to the center for 5 days or 4 days? Why not go to the field? And like what Femi was saying, that the training happens in the surrounding of the health worker. So the health worker can say, all is well, but you know, I don't have a safety box. Or all is well, but I don't have a temperature monitoring device that works. So yes, I think that it is important to have that interaction through a field visit.
Let's also just cover the measurement aspect, which was brought up. Sarah, as a government institution under a lot of pressure to measure the results you're getting for your investments, do you have a particular perspective on how you can measure something as difficult to describe as training or immunization training?
Sure. I mean, indicators are certainly a struggle in this area, and you know, we also are guilty of using the number of people trained, which doesn't really tell us anything about the quality. But I think looking at project data, for instance, to Femi's point, the core group polio project, where we've used community-based training, really taking it down to the field, and not necessarily for service delivery providers, but training community-based health workers on communications, on things like tracking of newborns and the importance to get at why people aren't being vaccinated. So understanding those problems and questions, and then we have project data that shows that it does actually increase the timeliness and effectiveness of vaccines and increase in uptake, that we can kind of circle back that into our larger programming to talk about things for the following year. But we really do need to, measurement is just critical and key to anything, because if we're not producing the results, we're not going to continue to receive funding, you know, in our case from Congress, to keep implementing our programs.
I think measurement is going to be a big theme throughout the Congress. I know this table is going to be next. Lauren, thank you.
Thank you very much, and thank you to all of the panelists. 3 things. In most cases, we are not addressing the people that need the training most. When we are doing this cascade training, by the time we arrive at the operational level, the resources are finished. So usually we stop at the district level, and the people that need the training most are not addressed. So I think we also need to start thinking, how do we start with the people that need the training most at the operational level? This was on the issue I think we need to think about when we are discussing this training. And also the facilitators. Usually, because you have been nominated at national level or provincial level, you become automatically a facilitator of this program, where you don't have any idea, you don't have any pedagogical skills, but because you have the responsibility of this program at national or provincial level, so you are nominated a facilitator for the training, and you don't have any skills on that. So we really need also to think how we can advise maybe the countries, the people at national level, how do we make sure that the people that are being facilitating this training are some of the people that have at least some pedagogical skills to be able to provide the trainings. And the other thing is the integration. At operational level, things are integrated. So when we come with immunization, tomorrow is HIV, after tomorrow is the malaria, how do we make sure that these trainings are kind of integrated at operational level, and that people that provide it have a kind of minimal background? Because at district level, usually it's the district medical officer that will be providing the training to the people. And this district medical officer is called every time for all the programs are calling him. This week is malaria, next week is HIV, the following week is immunization. He doesn't have time to really train his people at operational level. So all these things, we need to really think at the context we are delivering this training. So, and try to think on which innovative methods, and we have heard some of the panelists talking about innovative methods, videos. We also are trying to see about how do you call it, self-learning approaches, so that the health worker can do his learning at his own pace. So all these things that we need to take into consideration. We are sorry to be a bit long, but there are so many things. Thank you.
Again, a rich series of questions around how do we get resources down to the very field level in countries. I'll paraphrase slightly what you said. Are our trainers talented enough as trainers as well as technical people? And how do we actually integrate things at the operational level in a way which is truly practical? Perhaps we can address first getting resources down to the field level. Chizoba, from your work in Nigeria, do you see this as a very concrete challenge as well?
Yeah, it is. I was very happy with her submission. It's a very big challenge. How do you ensure that the health worker who is the target of the training actually enjoys the benefit of the training? It's a difficult question. One of the ways we are solving it in the project, the Step-In project, is to have at the state level core trainers, who then train the health workers. So we essentially cut out the middleman. At the
district level.
Yes, in fact, it's at the state level, and then we pull the frontline health workers to the state to be trained by the core trainers. So it's the core trainers training the health workers directly, not through several other steps. But that's expensive. And then it raises the question of how do you scale that up? And then it brings in the issue of, can you have partnerships with academic institutions? Because that's what they do. Training is what they do. Can you bring in teachers whose day job is to teach and to train to help constitute that resource of trainers at the state level that can train directly? I think also we have to use blended learning, like she talked about. What are the things that health workers can learn on their own through videos, so they can do it on their time? Because we also have to balance the fact that you can't take them away from the health facility for 5 days. Who is going to take care of the children? Who's going to do the vaccinations? Some health facilities have just one health worker. So could we then find ways of using videos that they can learn on their own, and then focusing on those aspects that require practical demonstration, that require facilitation, and kind of limit, so make it blended in a way. We have to experiment, and then the powers that be have to be willing to allow that experimentation. They also have to be willing to be open to independent evaluation of what they're doing. So, so that we don't spend the next 10 years, going in one direction only to wake up at the end of 10 years and say, oh, wow, this didn't give us what we wanted. So we have to build in the evaluation, the independent evaluation, as we go along.
And Hardeep, maybe I can ask you about this question about, are our well-qualified technical people also well-qualified instructors and trainers? Can you be both, or is there a trade-off?
You can be both, but there is trade-off. What we're doing in our approach to the training is slightly different. What we're looking at is there are at least 4 or 5 levels where the training happens. So the national level needs to have certain competencies. They need to know certain things, how to create policy, how to create guidelines, etc. Then there is the next level, provincial or the regional level, which has a different role. And then you have a district level where they're sort of more operational. and really where the rubber meets the road, or the tail end, or the last mile, where the health worker actually delivers the vaccine. So in the cascade, and my opinion about the cascade training is that inherently it is not the right approach for what we're trying to achieve. We should have different approaches for different levels. So for example, at the national level, the skills are highly specialized. You need one-on-one face time to learn those skills. You cannot learn it in a big classroom setting. It is small group, a low ratio to teacher to the trainee. At the provincial level, it's a different approach. The base gets a little broader. At district level, it is even broader, and you can look at with the newer technologies whether we can do e-learning and get the message or get the guidelines or get the new messages across a wide variety of, a wide base of people. But at the health facility level, that's where I feel that, as Anya Blanche very well said, that this worker is a multi-purpose worker. Immunization is one of their 20 jobs. They do HIV, family welfare, clinical work, you name it, there are 10, 20 public health programs they have to run. You cannot take them away, from work and bring them to the district level and train them for 5 days. Who will do those 20 programs for those 5 days? They invariably then lag behind. They do not achieve their targets, and then these trainings are to be actually blamed for them be away from their workplace. Do they really need to be away from their work? Or do they really need those 3 days? What we feel is, and we are sort of nailing it down now more precisely, that for a health worker at a facility level, invariably all they need is a job aid. They need not to be in a classroom setting to learn everything about immunization. What they need to know to do their job at their level, which is part of their 20 things, that's one thing which we are looking at. It just needs a job aid, and that's what we should focus on. So you really do not need the same methodology at all levels that we should hit. And some of the approaches which we have done is that for the health worker level or the health facility level, START program, and one of the posters yesterday is in START, I think it should still be out there, is a mentorship that you visit the health worker in their workplace and train them on their things, in their workplace, on their real data, on their real stuff. That's one approach, and it's working. We've done it already in four countries. Sustainability is still at a question, but it works, that you train them in their workplace, and suddenly there is more workload. The person who's gone there to mentor them, train them, he takes a pause. They say, okay, take care of your high workload. We will wait, and we will let you know more stuff later. The other approach is part of the system, and that's approach we've done in India, in state Rajasthan, which is 77 million people, so it's like a big country. There it's called Capacity Building Initiative for Routine Immunization. As part of their routine monthly meeting, the health worker from a health facility comes to the district level for submitting their reports and doing a touch base for getting money and other things. During that time, it's a whole day meeting, we take only 30 minutes. We train them on one small item of the immunization system. Show them what really needs to be learned. There are only 3 points made. One small exercise, 10 minutes, and then they go back to their workplace and they do the exercise on their own data, in the real data. And as the next time they come back for a monthly meeting, their assignment is reviewed and they are given another assignment for 30-minute lecture. And that has worked over time. This has been over 4 or 5 years now. It's a slow process, but the base is so broad that we are seeing some system change there, which is important. Then it is very low cost. Essentially, what we are doing is just printing those materials. That's it. It's part of the system. So there are other approaches to cut the cost, the resources getting down to the last mile, and approaches has to be tailored. What is needed, do only that, not that we have to do a training at national, provincial, district, and health facility level.
Thank you.
That's it.
I saw quite a few hands go up here. What I would ask is perhaps if people just ask one question, that will give more opportunities for everyone to have a go. And Erin, you can pick a winner. So.
Thank you. I'm Hamid Reza from Gavi Secretariat. I have a question and a little bit of challenge to the stakeholders, if I may. The question is about, we are talking about trainings and teach to reach mainly as a means to get to our immunization outcomes. So why not for the measurement, we put our indicators at the delivery, at the results level of the program. So then we can address the needs-based, that what is the need to get to what we want to, and we can design the program in a way which is really tailored to each of the weaknesses of the operational system. That's my question, and I want the reflection. I have a kind of comment which is a challenge. I hear a lot of training, targeting, sending the message, and I see it very top-down approach. Why you're not talking about learning and making it participatory at the lowest level, things that we are saying, but again I hear a lot of approaches that is military, and the way that it's one-way communication. So that's a challenge to the stakeholders. Thank you.
So results-based measurement. Who would like to come in on that?
So if I got your question correctly, you were saying link training directly to coverage improvement, for example. Is that right? So the problem is that how do you attribute coverage improvement to one intervention? So there is.
Do I need to do that?
Sorry?
Do I need to do that? Attribution is not the case here. It's the outcome is the most important thing.
Yes. So in general, you could, so that's what we've been doing. Like also, Chizoba, in your project, you've taken 3 states where this intervention is happening, and if you compare it with other 3 states where the intervention is not happening, and then you see if there have been coverage improvements because of this intervention, and then you could target like that, and ultimate goal is coverage improvement. But sometimes when we try to attribute it to training, we are told, well, there were other factors, including leadership at that level, that drove that coverage improvement. But particularly in new vaccines and some specific new vaccines, like there was PCV10 where the health worker had to do a particular thing to discard the vaccine, and so we could really see if that action was done, and then we could definitely see whether the training was successful, so that the health worker didn't keep open vials in the refrigerator after the session. So those things you can directly measure, but a lot of times it's you can't really totally attribute to training. I don't know.
Yeah, if I may just add briefly, I think the challenge with attributing, or rather using coverage improvement as an outcome of training is that the more direct link from training or capacity is on the quality of the services that are delivered. Because there's so many other things, like you say, that contribute to quality. Whether a child comes to the health facility in the first instance to receive the vaccine may depend on their parents and the behaviors of the parents. So even if you have a very well-trained health worker at the health facility, that's demand. The demand side may not be there. But the one that has a direct relationship with the knowledge of the health worker and the practice, it's whether they are giving the injection right, whether they are recording the data properly, whether they are providing the information correctly. So things around the quality of the services that are delivered. But having said that, I think we have a challenge because we need to agree on, hopefully by the time we come out from here, we need to agree on maybe a minimum set of things that we should be measuring around competencies, around quality and things like that.
All these conversations can continue for the next 2 days. We're going to have to, unfortunately, let our panelists go in just a moment. What we'd like to ask you is perhaps just briefly say, in closing of this panel, what do you really hope for most to come out of these next 48 hours together? I'm going to start with Liya.
I was part of this summit last year, so I have seen many interesting theories that could have been practiced for the past few years. So this year, my hope is to find out, to identify best practices that can be implemented in my country's context. So I'm looking for best practices that we can adopt and practices and improve the overall immunization trainings.
Thank you. Jhilmil, what do you hope for most?
That's the same, and also I think that this is the second time that we are meeting, and yesterday in the poster session there was a lot of energy and people, you know, wanting to do make the change. So I hope that after this meeting, during the meeting and after, we form a network of change, you know, to bring about that change, and you know, we probably use the technology and we stay connected and you know, work together on these issues.
Sarah?
Yes, I think about that lovely change slide with the key and the globe picture. I mean, really, things that we can operationalize, things that we can walk away here and have measurable actions to do. As part of the incentives group, I'm very interested in this idea. Our agency has done some formative research about what motivates people, and I think really, you know, to step back and think from ourselves and from the different levels of motivation and tailoring things to meet people's needs, to really sort of spin the space over the next few days to explore that a bit farther.
Chizoba?
So I was here last year as well, and in that time to hear, one of the things that struck me is that we need to also think about the change management process at the, you know, back there among people who are not here. That we need to think about the political economy of changing the status quo as we are trying to prescribe here and work specifically on that. And then the second thing is, how do we bring these things to scale in a way that's affordable? That has really been the challenge. And I think I appreciate that example you gave from India about just using the monthly meetings as an opportunity to do a little bit of training. So how do we bring this to scale? How do we measure it? And then how do we measure how much we are spending on it?
I'll give Hardeep the final word.
Okay, thank you. So I'm really excited to be part of this talented group of people with diverse expertise. And I'm really looking forward to one important thing, that the working groups are going to define some things here, so the plans. And that is what is going to give us sort of direction to the future, the way we will do the business of training. So that's my really excited thing to look forward to during these 2 days.
Great.
Thank you.
I know a lot of people didn't have an opportunity to ask their question, but we do have coffee breaks, lunch breaks this evening. You can follow our panelists around and ask your question, or perhaps during the course of the day. But if you don't mind, let's just give a round of applause to everybody and thank them for their words.